Sirs, is my presentation visible? Sir, is my presentation visible?
Yes.
Okay.
Make it full screen, ma. Yes. The slides.
Yes, sir.
Please run through the remaining slides till the end, sir.
Yes. Yes, sir.
Please unshare
Yes,
the
sir.
screen now.
Yes, sir.
Professor Hidao, sir, thank you for joining, sir.
Okay, thank you.
Good evening, friends. We warmly welcome you, all of you, for the
Hello.
edition. Am I audible, sir? Who is
Yeah.
that, sir?
I am Dr. Jagdish Hidao.
So, yes, sir. I got it. Many people name are an iPhone like that. Thank you very much. So, good evening, senior professors. We have the honor of having Professor Nishikant sir, Professor Jagdish sir from Nagpur, and then Professor Saha sir from Kolkata. And we have our senior faculties, Dr. Srinivasan sir, Rajiv sir, and others we are expected to join. Today we have two presentations, one from Stanley Medical College and other from Kanyakumari Medical College. We will have the Stanley Medical College presentation to go first. Can we have the honor of having Bhuvanesh? Please share your PPT, introduce your
Yes,
unit chief, your head of the department, and start your presentation. Good luck to you.
thank you.
Go to the first slide, ma. We are unable
Good
to
evening.
see you, Bhuvanesh.
Sir, am I visible now? Am I visible now, sir?
Hello.
No, ma.
Sir, is the presentation visible?
Yeah.
Okay, sir. Yeah. Okay, sir. Okay. So, sirs, may I start?
Bhuvanesh, we
Yes,
are
sir.
unable to see you unless that is sorted out. We will not be able to start, Bhuvanesh. Do something. If you want time, we can present as your case as a second case. Without seeing you, it becomes difficult for the faculty to take your presentation.
Oh, okay, sir. I'll try.
Galaxy tab.
Ganapati,
Yes, sir.
you please share your PPT and start your presentation.
Okay, sir.
Hidao sir, good evening.
Good evening. Good
Good evening,
evening,
sir.
Nishikant.
Good evening, sir.
Sir, Nishikant sir, your student.
Yeah. Happy to see you.
Thank you, sir. Thank you.
Dr. Ganapati, introduce yourself.
Sir, shall I start, sir?
On your video. Yes, you are good to go, ma. Good luck to you.
Good evening, professors. Good evening, Onnanal. I am
Good
Dr.
evening.
Ganapati, final year postgraduate from Kanyakumari Medical College. My head of the department, Professor Dr. Jayalal, sir. Shall I start my presentation, sir?
Yes.
52-year male who is a daily wage laborer by occupation, residing in Nagarkoil, came with chief complaints of swelling in the front of the neck for past 2 years. Patient was apparently normal before 2 years, after which he noticed the swelling in front of the neck in midline for past 2 years, which was insidious in onset, initially small, and then gradually progressed to attain the current size of 4 centimeter. It is painless. No history of dyspnea or dysphagia, no history of hoarseness of voice, no history suggestive of hyper or hypothyroidism, no history of any other swellings in the neck, no history of loss of weight or appetite, no history of bone pain, no history of cough with hemoptysis, no history of jaundice. Past history, patient has no known comorbidities, no past surgical history, and there is no history of irradiation in the past. Family history, no history of thyroid swelling in the family members. Personal history, he is a mixed diet consumer and has a normal appetite, consumes alcohol, and he is a smoker for past 30 years. Bowel and bladder habits normal, sleep pattern normal, no history of thyroxine or any antithyroid drug intake. Coming to the summary, a 52-year aged male with no comorbidities presented with painless progressive swelling in the midline of anterior aspect of neck for the past 2 years with no history suggestive of pressure symptoms and no future suggestive of hyper or hypothyroidism. Sir?
Hello,
Yes, sir.
Ganpati. Why you ask history regarding irradiation of the neck?
Sir, any childhood irradiation would predispose the patient to papillary thyroid carcinoma. It will take a incubation period of 20 to 30 years. For any Hodgkin's lymphoma,
Childhood irradiation regarding which conditions?
like low dose irradiation for any tonsil or adenoid enlargement, or if Hodgkin's lymphoma, mantle radiation would have been given in childhood, sir. If that has
Previously they used irradiation benign condition, thymus, active. So
sorry, sir,
later on it is found that it developed into the papillary carcinoma. So at present, which is the commonest condition that causes development of papillary carcinoma?
commonest condition.
Just now you told
Sir?
lymphoma,
Lymphoma.
non-Hodgkin's lymphoma.
Okay, sir.
One more question I want to ask you: how radiation causes malignancy?
Sir?
How irradiation causes malignancy?
Sir, sensitizes the thyroid mutation in the thyroid, sir. Any commonly associated mutations like BRAF or P53 mutation.
Okay.
How does irradiation normally cause malignancy in any other condition?
How many?
How does irradiation cause malignancy in any other condition?
Sir, irradiation might induce a mutation in the predisposing mutation in the thyroid follicles, which may.
Irradiation per se prevents repair of damaged DNA.
Okay, sir.
That's how it is.
Okay.
The audio is not very clear from the sir who was talking.
Yes. Most of the time.
Ganapati, can you tell me the significance of your mention about the family history, specifically in the thyroid?
To rule out any associated syndromes, sir.
This specific pathology where it is very, very important.
Men's syndrome, sir. Most commonly, men's syndrome associated with medullary carcinoma thyroid. Other possibility.
Other
possibility would be a familial adenomatous polyposis, which would be associated with the papillary carcinoma, sir.
Okay.
Or also Gardner's syndrome.
And if suppose there is a family history present in such case,
yes,
how does it matter? If suppose you get a patient early age and this
go ahead with the genetic analysis, sir. If it is If it is men-associated medullary thyroid carcinoma, we can do exon study earlier, and we can decide on the prophylactic thyroidectomy, which can be planned earlier, sir, based on the risk stratifications.
Dr. Ganpati, can medullary carcinoma thyroid occur other than in Men's syndrome?
Sorry, sir, I am not able to get it.
Can medullary carcinoma of thyroid?
Yes, sir.
Okay, I'll just see it.
So, can medullary thyroid carcinoma cause?
Can medullary thyroid carcinoma occur other than in Men's syndrome?
Yes, sir. It can occur as a familial form alone, sir. And apart from that, it can occur in isolation also, sir.
Right. So just don't say Men's syndrome. It can occur without Men's syndrome also.
Yes, sir. Yes, sir. It can occur, sir. Men's syndrome. Without Men's syndrome, it can occur. Medullary thyroid carcinoma.
Ganpati, you are asking the history, family history of thyroid for the reason for the syndromes only?
No, sir. To rule out endemicity also, sir. If they are living in a...
That is probably the first thing, isn't?
Okay, sir.
Endemicity is the first thing. You know? It may be just a simple benign colloid goiter, multinodular goiter.
Okay,
And
sir.
not only the family history, you have to ask the history about the surroundings also.
Okay, sir.
Okay, if anybody has got the multinodular goiter or not. Okay, based on the clinical history only, what is your suspicion? What is the probably diagnosis here?
Sir, it is a painless progressive swelling which is being there for past 2 years, sir.
Yes.
From the history, I suspect it to be a solitary thyroid nodule, probably of benign etiology, sir. Since there is no features to suggest it as malignant etiology from history, sir.
Right. So why you were thinking it's a thyroid swelling?
Sir,
Only on the history, you know, only on the history. What is the commonest swelling of the neck?
neck node, sir, lymph node.
Yes, lymph nodes. And what is the universal tumor? What is the universal tumor? Lipomas, you know?
Okay, sir.
Okay, lipomas are the universal tumor.
Okay, sir.
So the commonest cause for the swelling in the neck will be the lymph nodes or the lipomas.
Okay, sir.
So why did you think about the thyroid in this patient? That's what I'm asking.
Sir, it has been progressively.
Do you get the lymph nodes in the midline usually?
Sir, can be a possibility of pretracheal or prelaryngeal, sir, but it is
Very less, very less.
Very rare, sir, compared to thyroid.
Yeah, lymph nodes are much more common in the lateral compartments,
Yes, sir.
not in the midline. Yeah.
Okay, sir.
Okay. Similarly, the lipomas also.
Okay, sir.
They are more common in the lateral compartment than in the midline. Okay. So that is why probably you are thinking that it is a case of a thyroid swelling there.
Okay.
Why it's not a thyroglossus cyst?
Sir,
Only on history, you know, I'm just only on the history. Why it is not a thyroglossus cyst?
the age of the
What is the
patient.
coverage of
Age of the
presentation in
patient.
thyroglossus?
That is the age of the patient. You know?
Age of the patient.
Yeah, he's 52 years.
Yes, sir.
Okay, so that is the right. Why it is not a sublingual dermoid?
Sir, dermoid, it has to be either sequestration or implantation one. Age again is a factor, and there is no history of any trauma to suggest.
You know what are the various types of dermoids?
What is the location you can tell so that it gets very clear idea? Location of sublingual dermoid. What are they? What is the site other than midline?
How you differentiate between thyroglossus cyst that from the dermoid cyst?
Sir, on examination, it moves with protrusion.
Just now sir told you, na? Sir, give the clue.
Position, sir. It will be in midline, and it will be more commonly in suboid region, sir.
It will be
dermoid will be a
much at the higher position, hai na?
higher position.
And again, a younger patient.
Okay, sir.
Okay, patient will be young and it will be at a much higher position as compared to probably your patient, which is at the lower one. You know what are the various types of dermoid I asked you?
Sir, sequestration dermoid, implantation dermoid.
Yes.
Other two types.
Thyroglossus cyst comes under dermoid or no?
It is a embryological remnant, sir. Can be considered.
What is the
Tubuloembryonic
embryonic variety?
Yeah.
Tubuloembryonic variety?
Yes, sir. Thyroglossus cyst can be considered under.
Tubuloembryonic variety. Hai na?
Okay, sir.
Yes. What is the commonest site of the dermoid?
Sir, much lower, the suprasternal region, lower border, along the lower border.
It doesn't occur in the neck, you know. I'm asking the commonest position. It doesn't occur in the neck.
Commonest, sir, upper limb, sir, forearm and hand.
No, not in the forearms and hands. Somewhere in the face itself.
Sir, along the fusion line, sir, outer canthus, outer aspect of
Outer canthus, external angulodermoid.
angular dermoid.
That is the commonest site of the dermoid, external angulodermoid. Okay.
Okay, Ganpati, I want to disturb you, ask you one question. Just now you told you that MEN1, what is component of MEN1 and MEN2?
So in MEN1, there will be a parathyroid tumor, sir, mostly prolactinoma. Sorry, pituitary tumor, mostly prolactinoma. Parathyroid hyperplasia will be there, and associated pancreatic tumor, more commonly gastrinoma will be there, sir, in MEN1.
And in MEN2?
2A, pheochromocytoma, medullary thyroid carcinoma, and parathyroid adenoma are common.
Okay. How medullary carcinoma will present commonly? What is commonest presentation of medullary carcinoma of the thyroid?
Sir, it will be having an indolent course, sir. Long standing, it will be there, sir. And mostly patient.
Commonest symptom. Commonest symptom.
Pain will be there, sir. Associated.
Huh?
Pain can be associated. Pain can be there, and
A very peculiar symptom in 30% of medullary carcinoma.
Maybe due to other secretory substances, flushing and the bowel disturbances.
Diarrhea.
Diarrhea, yes, sir.
So what are the causes of diarrhea in case of thyroid condition? In thyroid, there are two causes of
medullary due to serotonin.
Is medullary carcinoma. Any other condition?
Sir, hyperthyroidism.
So what is cause for a medullary cause for diarrhea in case of medullary carcinoma and cause for diarrhea in case of hyperthyroidism?
Sir, in case of medullary, it is due to the neurotransmitters which are secreted, sir. 5-hydroxytryptamine. Yes, sir. In hyperthyroidism, there is a increased metabolic rate and increased bowel movement, sir, which is
increased mortality.
Mortality, sir.
Okay, good. Proceed.
Sorry.
Dr. Ganpati, yes, by your history, what do you think you're dealing with?
Sir, DD, sir.
What could be a case?
Neck swelling probably of thyroid origin, sir. But I want to give other DDs would be a lymph nodes sir, possibility, but rares are still rare, and thyroglossus cyst still the age is not common, sir.
No, Dr. Ganpati. This is in the thyroid region, right? So you think of a thyroid. Don't. You can't give me a list of all the differentials: lipoma, thyroglossus cyst, dermoid cyst, lymph nodes. Just say it's a thyroid. Now, what kind of a thyroid swelling could it be? 2 years, no other symptoms.
Sir,
No growing.
Can be a malignant one, sir. Having a
Why do you think it's malignant?
So it's a male gender and having a indolent course for a long time, for 2 years.
So indolent course is malignancy. And benign tumors are fast
No, sir.
increasing.
Usually, malignancy will be associated with the rapid progressive increase in size, sir.
So what do you think
Recently,
this patient is having? Is it rapid growth?
no, sir. No, sir. But,
So what do you think is the diagnosis? Could be. What could be the cause? Okay, give me the types of differential diagnosis of thyroid swellings now.
a solitary thyroid nodule, multinodular goiter, can be a malignant condition which includes papillary follicular, sir.
Is benign adenoma more common than malignancy, or is less common?
Benign adenoma are common, sir. More common.
Much more common.
Yes, sir.
Much more common.
Yes, sir.
So why aren't you taking it? It could be a cyst, it could be an adenoma, it could be a dominant cyst of a multinodular goiter. Malignancy is quite rare. It's not that common.
Okay, sir.
How many malignancies have you seen of thyroid in your 3 years? Not much.
Yes, sir.
Okay. So should we proceed to the examination?
Clinical picture of the patient, sir.
Yep.
On general examination, patient is conscious, oriented, afebrile, well-built and nourished, no pallor, no cyanosis, no clubbing, no icterus, no lymphadenopathy, and no pedal edema. Vitals, BP 124/78 millimeter of mercury in right arm in sitting position, pulse rate 78 per minute, normal in rate, rhythm, and volume in radial artery, right radial artery. Examination of the thyroid region. After getting consent from the patient examined in sitting position in a well-lit room. On inspection, a solitary swelling of size 4x4 cm, hemispherical in shape, located in the thyroid region in the midline, with smooth surface and well-defined margins. Lower border is seen. The swelling moves with deglutition and not moving with protrusion of tongue. Skin over the swelling is normal. Trachea appears to be in midline. No other neck swellings. On palpation, there is no local rise of temperature, no tenderness. Swelling in the thyroid region of size 4x4 cm, hemispherical in shape, located in the midline, smooth surface, margins well defined, firm consistency, and lower border palpable. Trachea central in position, both carotid fell. On Lagis test, no posterolateral extension of the swelling fell. Cryles test, no other nodule palpable, and no palpable neck nodes. On auscultation, no bruit heard over the upper pole of the thyroid, no eye signs, no tremors. On systemic examination, CVS, S1, S2, no murmurs. CNS, no obvious neurological deficit. RS, normal vesicular breath sounds present, no added sounds. Per abdomen, no organomegaly, bowel sounds present. Skull, spine, and scrotum normal.
On inspection, you said trachea is central. Can you really comment on trachea on inspection?
Sir, not any obvious. We can't say any. We can't come to an accurate conclusion, sir. But no obvious deviations, sir, due to no prominent sternocleidomastoid on either side, sir. Indicative of not.
Okay, Dr. Ganapati.
Unless there is some big, yes, go ahead.
Yes.
Dr. Ganapati, just
Yes,
on your auscultation,
yes, sir.
I think by mistake you put tremors and eye signs. That
No,
should
sir,
be on.
that is a separate one, sir. I didn't. Sorry, sir.
Okay.
Auscultation includes some of the bruise.
Let's go back to your first slide on examination. Okay. Have you tested for his reflexes?
Sir, reflexes. I tested for the tone of the muscle, sir. Since there is no
tone of the muscle. What do you test for the tone of? Why do you test for the tone of the muscle?
No, sir. Whether any proximal muscle weakness, as in.
How did you test for that?
Sir, by inspecting the patient, whether he is able to get up from the sitting position without any difficulty.
Have you mentioned it?
Sir, since no features of hypo and hyperthyroidism,
have you? No, but you got to be examining the patient.
Yes,
look, hypo and hyper. This thing is they are all history. They are subjective. They're not objective.
Okay, sir.
So you got to look for objective signs, no?
Okay, sir.
So this is one of them. You've got pre-tibal mixture, which is another one of them.
Yes, sir.
Clubbing is there. These are objective signs.
Okay, sir.
right? So you got to at least mention them. Reflexes.
No
So that you
eye
show by
signs.
exam. Right. Eye signs, that's fine. But there are other signs also which tell you that whether the patient is having any features of hyperthyroidism or not. Right?
No,
Hyper
sir.
or hypo. Right. There should be.
He's not having any symptoms of hyperthyroidism, sir, like sweating.
Okay. Let's go to the next slide, please. Lower border is seen. What does that tell you?
Sir, there is no retrosternal extension, sir.
Okay. And if there was one, then?
We can ask the patient to swallow and see, sir, whether the lower border gets visible on movement with the deglutition, sir. And on palpation, we need to make out whether the lower border is able to be made out or not.
Any other way of trying to push it out?
If it is completely intrathoracic, if the patient coughs, it may come out, sir.
Okay, a Vulsa was would push it out.
Any other maneuver to see it? Ganpati? To test the retrosternal goiter?
Pemberton sign.
Pemberton sign. Even in general examination, you have not mentioned about tremors and all these things.
Tremors,
Yes, mentioned.
Okay, correct, sir.
Dr. Ganpati, actually,
as a part of protocol, you have to mention it.
Right.
Yes,
Ganpati, when you're examining a patient, by examination, your features of function should be seen together. Your features of malignancy should be seen together.
Okay,
you can't just write them here and there. Okay, it's not proper.
Right. I'll correct, sir.
Okay. Next line. Next slide, please.
Can you confirm on palpation that there is no retrosternal extension by simple examination?
Yes, sir. I was able to make palpate the lower end of the thyroid of the swelling, sir.
What do you palpate there?
Sir, if it is having retrosternal extension, we will not be able to palpate the lower border. Border was able to be made out, sir.
More specific than that. If you are able to palpate the tracheal rings there, that is almost confirmatory.
Okay.
Right?
Okay.
Your trachea cannot be palpable if there is because it is in front of it.
Okay. Sir.
Yeah.
Okay. Sir.
Yes. Good.
Okay. You said what about the consistency? It's firm.
Firm and consistency, sir. The swelling is.
So what is thyroid paradox?
Sir, in papillary thyroid carcinoma, cystic swellings can be hard and malignant swellings can be soft in nature, sir. That is called as thyroid.
Is it only for papillary thyroid carcinoma, or is it for
no, sir, it applies to everything, but most commonly seen with papillary thyroid carcinoma.
Just because papillary is most common doesn't mean that it's only seen in papillary. Okay. Okay. What is Lahey's test? Why do you do that?
Since I'm able to make out a swelling in the classical method, I want to rule out any posterolateral extension is there or not, sir.
Why do you need to do that? I mean, was it necessary to do that? Because your swelling is 4 by 4 centimeters. It's not extending going anywhere else.
Yes, sir.
Ganpati.
Yes, sir.
Just now you told that Lahey's method is for classical. It is a classical method.
No, sir. If classical, if you are able to make out a swelling,
so how many methods are given in clinical tasks for palpation of the thyroid?
Classical Pizzolat's method, sir. Lahey's method.
Pizzolat's method is for inspection.
Inspection, sir. Classical method, Lahey's method, Kryle's.
What is meaning of classical method? How to palpate it?
Asking the patient to clasp his fingers and taking it back to the occiput and extending the neck.
That is Pizzolat's method, right? That is Pizzolat's method.
And standing from behind and palpating.
Standing from behind the patient, you have to keep both thumbs over the occiput and 4 fingers over the gland, neck. So what is role of thumb here and what is role of 4 fingers? Thumb helps in the extension and flexion of the neck, and with concavity of the 4 fingers, thyroid gland is better palpable.
Yes, sir.
Then what is role of importance of Lyle's test?
In this patient, the swelling is well-defined margin, sir. If any doubtful extension posterolaterally,
In classical method is for complete proliferation of thyroid. Lyle's method is for
It is specific for what?
specific for
Not
what?
posterolateral aspect.
It is not applicable in this patient, but otherwise also, if you do Lyle's method, what for it is done? That's the question.
So it is done to look for any lateral extension, sir.
Not
If the
lateral.
border is not able to made out, if it is any extension into the lateral.
Just explain me what is Lyle's method, how to perform it.
So the gland is pushed from one side, and we are.
So where should examiner stand?
So from the front, sir. Front.
The right hand is used for which?
The right hand pushes the gland from one side, and on the diseased side, lateral aspect is made out, sir. But for
palpation of the lobe.
Lobe, sir.
Lyle's method is palpation of the lobe.
Diffuse enlargement.
And specifically for the posterior part, anteriorly you can palpate by classical method, right?
Okay, sir.
But posteriorly, once you push it, you can palpate the posterior part also. That is one of the significance of this specific method. Okay?
Okay, sir.
Right.
Yeah, Dr. Ganpati, you said that the swelling is in midline. It's not in the either of the lobes. So you think it's arising from the isthmus?
Yes, a possibility of isthmus origin is there, sir. It is more confined to the midline only, sir.
Are isthmus swellings in the located just to the isthmus very common?
No, sir. It will have a extension, sir. Since active area is isthmonodular junction, it will have extension.
Let's see the picture of your patient, please.
Yes, sir. Yes, sir.
Look, this picture is hardly his neck. You should have taken a picture with his neck extended, isn't it? You can hardly make out, but probably it could be. You can't make out whether it's on the left lobe or right lobe or just okay. So what is your diagnosis
in relation to the sternocleidomastoid?
Sir?
What is the relation of the thyroid swelling to the sternocleidomastoid?
If the swelling is going to push the sternocleidomastoid, it is going to precipitate trial signs, sir. But here bilateral sternocleidomastoid are not prominent, sir.
So that is for the trachea you're talking. I'm asking
Ganpati,
the relation of the thyroid to the sternocleidomastoid.
If it is going to be diffuse enlargement, the extension of the gland would be behind the sternocleidomastoid and either. It will cause.
And if it's not diffuse, it is not diffuse to go over the sternocleidomastoid.
Can go behind sternocleidomastoid and produce a protrusion.
Look, thyroid swellings will always go behind the sternocleidomastoid. Whatever is the thing.
No, sir.
They never go above the sternocleidomastoid. Why?
It is enclosed in the pretracheal fascia, sir.
Exactly. So
yes.
why should you say that when there's diffuse swelling, it will go, it will all that? Just say that it will always go down, go behind.
Okay, sir.
Ganapati,
both
can I ask a
carotids
question?
are felt.
Ganapati?
Yes, sir.
Yeah, can I ask a question? You said the swelling is free from the underlying structures. The underlying structures are trachea, esophagus, prevertebral muscle, and the body of the vertebrae. How do you test for whether the swelling is fixed to the larynx and trachea? What is the test for that? How do you say that swelling is not fixed to the trachea or to the larynx?
Sir, we can check for the mobility, sir, in both axes, sir. If it is going to be, if there is going to be any tracheal infiltration, mobility will be restricted in the vertical, horizontal axis.
Yes. What about deglutition?
Moving with deglutition will be seen, sir, but will be reduced.
Before you test for this intrinsic mobility, you have to ask the patient to deglutate. If the swelling moves up and down deglutition, what does it indicate?
Sir, there is no extra thyroidal. It is staying within the pretracheal.
That indicates the swelling is not fixed to the underlying prevertebral muscle and the vertebral body.
Okay.
It still can be it still can be fixed to the larynx and trachea. If it is fixed to the larynx and trachea, it will still move with deglutition. But intrinsic mobility will be lost. You cannot move the swelling with the trachea larynx being stabilized. Okay.
Ganpati, what are the various swellings which move with deglutition in the neck?
Thyroid swelling, sir. Thyroglossal cyst. Any cyst arising from suboid bursitis.
Yes.
Laryngocele.
Even pretracheal and prelaryngeal nodes also can, even though rare, they also can move with.
Yeah.
Ganpati, with thyroid swelling does not move with deglutations.
Anaplastic.
The commonest swelling, that is not commonest, but the commonest cause with thyroid swelling does not move with deglutition. Very large goiter.
Okay, sir.
And previous surgery.
You said both.
Have you heard of laryngeal crepitus as we were discussing earlier? Yes, Khanna sir, please go ahead.
No, you said both carotids are felt. Which carotid did you feel? How many carotids are there?
Right side and left side, sir.
How many?
Sir, we are going to feel the at the level of common carotid bifurcation at C6 tubercle, sir, or C6 vertebral level, sir.
That's what I'm asking you. How many carotids are there?
Either sides to common carotid, which divides into external and internal carotids.
Yeah. So there are 6 carotids, right?
Yes, sir. Totally
2
6.
common carotids, 2 external carotid, and 2 internal carotids.
Okay.
So which one did you feel?
Sir, at the C6 vertebrae level, there occurs the bifurcation of common carotid into external and we are palpating the common carotid at the level of common carotid bifurcation, sir, against the Chestnut tubercles.
So you are feeling the common carotid, right?
Yes.
If you have to feel the external carotid or the internal carotid, where you will feel that?
Sir?
If you have to feel the external carotid and the internal carotid, where you will feel that?
The internal carotid can be palpated intraorally in the tonsillar fossa.
Good. And external carotid?
So superficial temporal pulsation.
No, before that, superficial temporal is very high. Okay, you go in the upper part of the neck. Again, in front of the sternocleidomastoid, in the upper part of the neck.
Okay, sir.
Here, the common carotid, you are feeling the middle part of the neck.
Yes, sir.
Okay.
Ganpati, what is the relation of the carotid artery with thyroid gland?
Sir, it lies on the either side of it forms the lateral boundaries of the thyroid region, sir.
What is given in your book? Anatomy, integrated anatomy. Posteromedial, posterolateral.
Sir, posterolateral, sir.
Okay. Proceed.
Have you examined the eyes of this patient to look for the exophthalmos?
Yes, sir.
Okay.
On inspection,
what are the various ways to check for the exophthalmos?
Sir, we can check for lid lag sign, sir.
No, exophthalmos. I'm not asking the lid lag sign here. Exophthalmos.
We can do Gifford's test, sir. We will be able to avert the upper eyelid, sir, which would not be possible in a thyroid swelling, sir. If
on inspection, what you will see in the eye?
Upper sclera will be visible, sir.
Upper sclera. So you can see the limbus all around you, yes, or you can also see the upper sclera. So you can see it from the front. Any other way to see for the exophthalmos?
Sir, standing behind the patient and looking from top.
Yes, in front of the upper eyelid, you can see that. Or the third way to see for the exophthalmos? to see from the lateral side.
Okay, sir.
So you can examine from the front, you can examine from the back, and also from the lateral side. Now, out of all those eye signs which are there, do you know what is the sequence of these eye signs? Which one is the first one to appear?
Van Graaff sign, sir.
The Van Graaff is usually the second one. The first one is
Dull dimple.
Darrell impulse, upper sclera visible, sir.
Stellweg sign.
Stellweg's.
Okay, infrequent blinking, which is there.
Blinking.
Followed by the Van Graaff sign, followed by the Jeffrey sign, followed by the Möbius sign. This is the order of, if you have to elicit as the patient's progresses.
Okay.
What are the various ways to check for the trachea?
You can do trial sign, sir.
One is the trial sign, that is on inspection.
Okay, sir.
Then
the palpation with
palpation, okay. Yes. Any other way? Auscultation. You can auscultate in that area. See where is the trachea. Okay.
Yes, sir.
Now, why did you examine in this patient the scrotum? No, you said the scrotum is normal.
Sir, as a extension of the examination, I examined the spine, skull, and scrotum, sir. In a male patient,
But can you get anything in the scrotum which may be related to the thyroid?
In
very rare, but it can happen. Testicular tumor, no?
Yes, sir.
Testicular tumor can metastasize to the thyroid. Very rare. Okay, so you can justify by that I examined the scrotum of this patient. Okay. So, what is your diagnosis now after the examination?
Sir, the patient is having a painless progressive swelling for the past 2 years, which is occupying the midline of the anterior aspect of the neck with well-defined margins and lower border is made to be palpable. It is a solitary thyroid nodule with patient in euthyroid state, sir, without retrosternal extension. I want to give a benign etiology, sir, but solitary nodule in male patient, better to rule out malignancy with investigation, sir. So before ruling out, I am giving a malignant etiology.
Is it good to put the malignancy here as the first diagnosis?
No, sir. First diagnosis is a benign disease only, sir. But since male patient with age more than 50 years, better to rule out malignancy, so probably malignant. Solitary nodule in a male patient.
Yeah, so should better to keep as a benign first.
Benign
That you can keep as a differential diagnosis of malignancy because there is no evidence of malignancy in this patient.
Okay,
it's there for 2 years, very slowly progressive, no pressure symptoms, no fixity. So it is better to keep as a benign pathology here and then, okay.
Dr. Ganpati, if it was malignant, what kind of malignancy would you think of? Such as long-standing, slow-growing malignancy.
Sir, medullary thyroid, sir.
Medullary thyroid. Why?
Yes, sir. Long-standing, slow-growing.
Is that
slow-growing?
Most common papillary only, sir. Long-standing history, most common papillary only. Sir.
Right. So with papillary, what would you find most commonly association? If it was papillary carcinoma, what would this be associated with most commonly?
Genetic mutation, lymphadenopathy.
Yes, lymphadenopathy. People answering, so you answer. Yeah, it's lymph nodes.
Yes, sir.
Right, so please.
Ganpati, which malignancy occurs after multinodular goiter?
Long-standing MNG, follicular thyroid carcinoma.
Follicular thyroid carcinoma.
Okay,
how will you proceed?
quadruple test?
As an extension of this examination, I will go ahead with the quadruple examination, which is clinical history and imaging and genetic testing, sir. Here in this patient,
No.
first
Go on, please. Just repeat the quadruple examination.
Sir, clinical examination, biochemical examination, imaging and genetic testing, sir.
Okay.
Genetic or histology?
It is histology. Genetics sometimes. It's nowadays people are adding it, but it is histology.
Okay, sir.
Right? It's pathological examination.
Yes, sir.
That's quadruple.
Okay, sir.
So in this patient, if you have to do a thyroid function test, which one you will do?
So TSH, sir.
TSH. Okay. And for making a diagnosis, that is for the screening purpose. And clinically, the patient is not having any symptoms of that. But for making a diagnosis, if you are given a choice,
yes, sir.
Which one test you are going to do?
Free T4 level.
Yeah, answers are coming here, na? Yeah, free T4. Yeah. Okay. Okay. Then after the thyroid function test, what is the next one you do?
For imaging, sir. Okay. To look for the nature of the.
Which imaging you are going to do?
Ultrasound, high frequency ultrasound, sir.
What is that high frequency?
So 7.5 to 13 approximately.
13 what?
Megahertz, sir.
Megahertz.
Yes, sir.
Okay, when you do abdominal ultrasound, you know, what is the frequency of the probe?
Sir, will be much lesser, sir, due to have higher penetration, sir.
Much lesser mean 1,
5.
2.
No, sir, 5, sir.
Yeah.
5 megahertz, sir.
Yeah, about 3.5 to 5G, na? Yes. When you do endoscopic ultrasound, what is the frequency?
3 to 5, sir.
No, endoscopic ultrasound. Very high resolution. You require a very high resolution.
Okay, sir.
Not requiring much of the penetration, but much higher resolution. So what frequency will be there?
20 megahertz.
Yeah, it's around 15. Yeah, na?
15.
Around. So intra-op ultrasound, which is there, or the endo ultrasound, it's around 15 megahertz.
Okay, sir.
Okay. So what are the findings suggestive of how does the radiologist they report the ultrasound? What do they say?
Differentiate benign or malignant, they say the nature of the echogenicity, sir. If it is more in range of hypoechogenic with high vascularity, we can also see for the lymph nodal status, as well as.
But they mention a very important thing always. What is that?
Thyroids. Thyroid imaging reporting.
Yes. They will tell about the thyroids. So what does the thyroids mean?
Thyroids 1 and 2, there is low probability of malignancy, sir. There is no need for FNAC, sir. From thyroids 3, if the swelling is more than 2.5 centimeter, there will be need for FNAC, sir. Thyroids 4, more than 1.5 centimeters, sir, more than or equal to. In thyroids 5, more than or equal to 1 centimeter, there will be need for FNAC, sir.
What is thyroid incidentaloma?
Sir?
What is thyroid incidentaloma?
Sir,
have you heard about that incidentaloma?
Yes, sir. Less than 1 centimeter.
So when you say it is an incidentaloma, you are right, and less than 1 centimeter. But
we are doing imaging for some other pathology and finding out.
So, which is that some other pathology?
Any node, cervical node, if you are trying to make out and incidentally find out.
Any other real cause, apart from the lymph nodes, which is there, any other cause for where you do a screening in that area in an elderly patient? You want to look for the carotids there. Okay, the patient might be having the TIA, and ischemic stroke may be there, transient ischemic strokes. So you have to see for the carotids, and that is the commonest reason for carrying out the ultrasound, and where you can detect that there is a less than 1 centimeter thyroid nodule is there. What is the adrenal incidentaloma? When you say it is adrenal incidentaloma?
So imaging being done for any renal pathology and find out.
So what is the size there? Here you say it's a 1 centimeter. What is the size there?
Less than
4 centimeters, है ना? 4 centimeters.
4 okay.
Okay. The patient is asymptomatic. You are doing something else, and you find less than 4 centimeter adrenal mass is there. Okay. So you have done the ultrasound. What is your next investigation?
Based on the thyroids, if there is a need for FNAC, I will go ahead with the FNAC, sir, to find the.
Okay. Imaging says it's a cystic lesion is there.
Yes, sir.
So what are you going to do?
We can, if it is a cystic lesion, we can try 3 attempts of aspiration, sir, and the cells can be sent for cytology, sir.
Right.
Since 10 to 15% of cysts can also be associated with malignancy, sir.
Which type of the cyst can only be aspirated? Which type of the cyst can be only aspirated? You are not bothered about any other thing there. If it is a unilocular cyst is there, okay, and there is no vascularity in the peripheries there. Okay, so you do the Doppler and you do not find any vascularity, then in that case you can attempt only for the aspiration there. But if there is any septations are there, any vascularity is there, then you should think that there may be a necrotic degeneration is there of any tumor. That should be kept in mind. Okay.
Would you like to palpate the cyst after aspiration and for what?
Palpation to make out the margin.
If you aspirate, would you like to palpate the cyst and for what?
Sir, to make out the surrounding areas, sir. After aspiration, any residual collection is there or not?
As sir was saying, it can be one of the, at times, degenerate.
Sir? Not audible.
Dr. Zivich, you are muted. Okay. In your patient, ultrasound has been done?
Sir, patient admitted today only, sir. Ultrasound alone has been done, sir.
Okay.
Right and left lobes are measuring out to be 4 centimeters, sir. And isthmus, there is a swelling of size 4.1 cross 2.9 centimeters, sir. They have given thyroids 3, sir. Patient is planned for FNAC, sir. Patient still on workup, sir.
Now you do the FNAC in this patient.
Yes, sir.
And your pathologist says it is a follicular neoplasm is there.
Yes, sir.
So how you are going to do get further?
Follicular neoplasm, yes. Patient is in euthyroid state, male gender, we can prepare him for surgery, sir. Since FNAC
can you
not
say
differentiate it
before that whether this patient is having the benign neoplasm or it's a malignant?
Only frozen section can make out, sir, or else we can do mass spectroscopy to
any IST markers which can help.
Elastography can be done, sir. Elastography, ultrasound elastography, if it is malignant, there will be hard texture, sir. If it is benign, it will be a bit softer texture, sir.
Okay. Any immunohistochemical markers which you can do to whether it is a benign or malignant? You can look for the Ki67.
Yes, sir.
Okay. That comes out to be positive, then it's more likely to be malignant. If it is negative, less likely to be malignant.
Okay, sir.
Okay. So you are planning in this patient, in a case of a follicular neoplasm, what would be your plan? What type of you are going to do surgery in this patient, isn't it?
Yes, sir.
Okay. So what type of the surgery you are planning?
Sir, if I have facility for frozen section, we can go ahead and differentiate whether it is adenoma or malignancy, sir. But since here
for
it is
doing a frozen section, you have to plan,
Yes, sir.
What is your
but
plan?
It is already 4 centimeter in size, sir.
Yes.
So it is better to go ahead with
yeah.
total thyroidectomy given the age of the patient.
Yes, he's a 52 years male patient with a 4 centimeter size.
Yes, sir.
Okay, it will be much better to go for a total thyroidectomy in this patient.
Total thyroidectomy, sir.
Right. So before you plan for the total thyroidectomy, what other investigations you are going to do?
Baseline TFT levels, sir. High calcium, baseline calcium levels, pre-op calcium levels.
Okay. What else?
If we are suspecting lines of other malignancy, we can look for.
No, we have decided it's a case of follicular neoplasm, and
Okay,
we
sir.
are planning for the total thyroidectomy in this patient.
Okay, sir.
Yes.
Uh,
One, you
TFT,
said you will do the baseline investigations, you will do a serum calcium. What
yes,
else? Will you do X-ray of the neck or not?
Yes, sir. X-ray of the neck has to be done, sir.
Why you want to do X-ray of the neck?
Sir, to know the status of the trachea, sir. And also.
So why you want to know the status? Where is the location of the trachea? What is the reason?
Sir,
And will you do only AP view, or will you do lateral view also?
Lateral view also, sir. In this patient, the swelling is very 4 centimeters, sir. In long-standing large goiters, there will be compression of the trachea, sir, which can give rise to scabbard trachea, sir.
Right.
That may lead on to intubation problems, sir.
You know
so
what is scabbard? What is scabbard?
A long-standing goiter compressing the trachea on mediolateral aspect, producing a sword-like appearance.
It's like a sword, you know? Yeah. Scabbard is a sword. Right. And why you do the lateral view?
So the extent of the if such
In
a
the
large
case of
swelling,
thyroid, why you do a lateral view?
so,
Any additional information you can get on X-ray other than this?
any other invasion or lymph nodes, invasion of other surrounding structures, sir.
No, we are doing plain X-rays, isn't it? It's just how will you see for the invasion and all those things, lymph nodes and all those. We are just doing a plain X-ray. So you have to go around the trachea only, isn't it? So lateral view is to see for the compression, no? Because if you do a total thyroidectomy and this is a long-standing goiter is there, what will happen?
Post-operatively, if you're going to extubate the patient, trachea can go into collapse and the respiratory distress can occur, sir.
Yes.
So in such patients, we need to pre-operatively plan post-op ventilation.
Sure. Okay. Any other investigation which you are going to do before you are planning with the total thyroidectomy? Are you interested to see for the larynx in this patient?
Sir,
Would you like to see the larynx of this patient?
yes, sir.
What is the significance of indirect laryngoscopy in such patients? Any patient of thyroid?
Vocal cord status has to be seen, sir. Pre-op vocal cord status.
Why?
Why you want to see that?
Why is it important?
Sir, to anticipate the if there is any already pre-existing paralysis is there or not, and to anticipate post-op respiratory distress, we need to go ahead with the pre-operative indirect laryngoscopy to look at the vocal cords and whether it is functioning properly.
And what do you understand by indirect laryngoscopy? Who does that?
Sir,
who does the indirect laryngoscopy?
Sir, clinician does, sir, by depressing the tongue, sir. In direct laryngoscopy only we can.
No, clinician. Which clinician will do indirect laryngoscopy?
ENT.
You are going as a general surgeon. You are going to do that.
ENT.
ENT specialist will do. So why it is called as indirect?
In indirect, we are going to depress the tongue with the tongue depression, and we are going to place a mirror on the posterior aspect. So it is going to give the appearance of the posterior.
You are looking through the mirror. You know, that is why it is called as. You are not looking directly, but you are looking through a mirror.
Yes, sir.
Okay, and who does the direct laryngoscopy?
Both ENT and thoraco means thoracic
you got the fiber optic, then the ENT person can do. But if it is not there, then who is doing the direct laryngoscopy? You're taking the patient the table.
Thoracic, the anesthetist.
Anesthetist will do that. They do the direct laryngoscopy there. Okay. Your patient is non-toxic, isn't it?
Yes, sir.
Okay. If there would have been some toxic symptoms, then how you are going to prepare a thyroid patient?
We need to check the baseline thyroid levels at T3, T4, and TSH, sir. Okay. And to bring that under control, we need to start the patient on anti-thyroid medication as well as beta blocker therapy, sir, for 6 to 8 weeks preoperatively. Once the patient...
so you give the beta blocker for 6 to 8 weeks?
Sir, till tachycardia settles down, which is associated with thyrotoxicosis. And
which drug you are going to give?
Sir, if propranolol commonly used, sir. If nadolol, it can be a single dose, sir.
No, not the beta blocker. Which is the drug which you are going to use for a long time?
Carbimazole.
Carbimazole.
Yes, sir.
Okay, so carbimazole you are going to give for 4 weeks or 6 weeks or 8 weeks or even 3 months, 6 months, but you are not going to give the patient the propranolol for so long, isn't it?
Yes, sir.
Propranolol is usually given
preoperatively to bring the
only in the preoperative period, sir, around 7 to 10 days before the surgery.
Yes, sir.
Okay, not for a long time, for 2 months or 3 months or like that.
Okay, sir.
And then if you have to give in the patient the propranolol, are you going to give the propranolol in the post-operative period?
Yes, sir. It has to be continued till 7th POD, sir. Since TF of thyroid hormone is T4 is 7 days.
Now, can you tell if the patient has got a thyroid storm is there after your surgery?
Yes, sir.
How you are going to control that?
Initially, we need to cool the patient with ice packs and start rushing IV fluids, sir, along with diuretics. It can be combined with digoxin to prevent any atrial fibrillation, sir. Along with that, propranolol IV can be preferred here, sir. Dose of 1 to 2 milligram per kg over 6 hours can be given, sir. Sorry, for 6 hourly can be given, sir.
What is precipitating factor for thyroid storm?
Preoperatively, if it is inadequate preparation, sir. Intraop excessive handling thyroid gland, sir.
How will you diagnose it intraoperatively?
High vascularity of the gland may indicate underlying thyroiditis.
How will you diagnose thyroid storm?
Intraoperatively, patient will go for atrial fibrillation. So first, initially tachycardia followed by AF, sir. That can be an indication.
So you are going to prepare the list for your consultant.
Yes, sir.
And there is a case of thyroid which has been controlled by your drugs. Okay. There are 3 gallbladders, 2 hernias, and 1 thyroid. Where you are going to put the thyroid case?
First as a first case, sir.
First case, yes. Why first case?
Sir, anticipating any thyroid storm and
well-prepared patient, if the environment is bad, he can precipitate that. So that is why patient anxiety has to be taken into consideration. That is one. And second, once you're doing a thyroid surgery, and if there is any complication which can happen, which can usually manifest in a very early, so you can very well watch that patient. And that is why the thyroid should be the first in the list.
okay.
What are the complications after thyroid surgery, Ganpati?
There can be a primary reactionary or secondary hemorrhage, sir, followed by
suppose in immediate postoperative period,
yes, sir.
patient develops stridor And on local drainage, there is no collection in the drain. Drain is functioning, not blocked.
Yes, sir. We need to release the tension initially, sir, and
No. Wound is healthy. Drain, suction drain is kept.
Yes, sir.
There is no collection, but the patient develops stridor.
Stridor can be due to nerve handling also, sir. Need not be nerve injury. We can try doses of steroids initially. Prednisolone can be tried for unless any strict fall in saturation, patient is able to maintain with O2. We can try prednisolone therapy and.
How the patient of hypocalcemia will present?
Hypercalcemia, initially there will be perioral numbness, sir, followed by weakness.
Okay, if there is a wound, there is hematoma, how will you manage?
Sir, we need to initially release the tension, sir, or else patient will deteriorate further. Release the tension sources and let out the hematoma and plan for the exploration to catch hold of the bleeding site and secure that.
Okay. And how will you manage the hypocalcemia?
We need to look at the. We need to preoperatively
also
look at
present with convulsions, stridor, periorbital.
Patient will have numbness and in the hands, sir, hands and peripheries, and patient may have stridor also, sir. We need to measure the post-op serum calcium level and compare it with pre-op, sir. And if it is if patient is presenting with symptoms and
what is immediate management?
Right, IV calcium gluconate, sir.
Okay. And in case of long-standing big goiter, which is the complication that can occur?
Collapse of the trachea, sir, due to long-standing compression, sir, post-operatively.
Okay, very good. Proceed.
Right.
Can I come in? I'm Dr. Dalvi.
Good evening, sir.
Good evening.
Sir, good evening.
Ganpati.
Good evening, sir.
Simple things.
Yes, sir.
Superior thyroid supplies what? And inferior thyroid supplies what?
Superior thyroid artery, sir.
Pardon?
Superior thyroid artery supplies the upper pole, sir.
Superior thyroid artery and inferior thyroid artery.
Inferior thyroid artery supplies the parathyroid and the inferior portion of the thyroid.
So then in examination, why do you look for a thrill in the superior thyroid area?
Sir, it is a first and direct branch of external carotid, sir. So
what?
Any changes in the hemodynamics will be more precipitated in superior pole than inferior
Correct.
pole.
So superior thyroid should be supplying what?
Anti-thyroid glands.
Pardon?
Thyroid upper.
This is the problem.
Majority of the thyroid.
I've just come in to just say that you know your theory very well. But practically, superior thyroid supplies the gland and inferior thyroid supplies mainly the capsule. And that's why the thrill is heard on the superior pole rather than the inferior.
Okay, sir.
So there are small things in examination which can tell you a lot of things and not rely on investigations.
Okay.
My second question to you is, in how many percentage of cases do you find actually a middle thyroid vein?
Sir, only 30% of the cases we can encounter.
Very nice. Again, theory. Very good. Very nice. What is the recent concept of going after the superior thyroid first and inferior thyroid later? What is your opinion?
The superior thyroid initial ligation, since it supplies the large section of the gland.
Exactly what I was trying to ask you. The first question was the same, which you could not answer.
Yes, sir. If we are ligating the superior thyroid artery,
surgery to go for the superior thyroid is only one. That superior thyroid supplies the entire gland on that side, and inferior has very little role. But then God has made such arrangements that inferior thyroids makes you difficult because the recurrent comes very near.
okay, sir.
My next question to you is, since you have answered very well, and I'm very happy about it, how does inferior thyroid supply parathyroid?
Inferior thyroid divides into its terminal branches close to the thyroid gland, and
That's why we now deal with the inferior thyroid very close to the thyroid gland.
capsular branches.
I'm asking you a question which is different. What is the blood supply of parathyroid arising from inferior thyroid? This is for distinction. Huh? This is not Ganpati for passing. My only suggestion to you is these sort of questions will come up when you start doing very well. Khanna sir is there now looking at me, and I have to retract. But Khanna sir has actually questioned you well, and that's why I came into the picture.
Okay,
Huh? So you know your parallel questions also well when you study anything about a gland. Thank you.
okay. Thank you, sir.
Ganpati, do you ligate the inferior thyroid artery?
No, sir. Main trunk ligation
Sir,
is
would
not
you like
made
to
out
ask any
nowadays, sir.
questions, sir?
You do not ligate, and you do the capsular
We
dissection.
go as
only.
close as possible and ligate like capsular branches.
Yeah, superior thyroid artery you ligate, but you do
Suppose.
not ligate the inferior thyroid artery.
Okay.
Dr. Kanagal, can we stop here?
Sir, I think we have one more case to go, sir. Other
please.
faculty, if they want to add any inputs, they can finish in 2 or less than 5 minutes. Then we move on to the second case.
We can move to the second case.
Can I come in?
Yes, sir. Please, sir.
Yeah, to all the PGs, once you are well read, you got to think about how you have worked in the ward. This boy has worked in the ward. He has worked in the OT. That much I can surely tell you. And then when questions go little laterally, little bit of information is important. Congratulations, Ganpati. I am very happy with you.
Thank you, sir.
Presentation.
Thank you, Dr. Ganpati. Done well.
Thank you, sir.
Ganpati, do you have any questions to get clarified from the faculty? Now that you have read prepared for this case, I'm sure you will have some questions. Would you like to ask any questions or doubts to the senior faculty here?
Is male gender and size alone is can be contributed to malignant etiology, sir? Or since if it is a solitary swelling in a male patient, the rule of 12 suggests that there is about 48% risk of malignancy. Can we contribute those two factors alone, and can we say it as malignant, or preferably we need to look at other pressure symptoms and come to a conclusion, sir?
Male patient may also have benign swelling. So just because patient is male and size is 4 centimeter, it cannot be equal to malignancy. You have to rely on other features.
Okay, sir.
I completely agree with Makan. Hi, Makan, I have not seen you for a long time. Yeah. See, you have to clinically examine the patient. And if you have features suggestive of malignancy, then go with the diagnosis of malignancy. In your case, I don't think there was any features suggestive of malignancy. Dr. Khanna tried to tell you it's mobile, it's this, it's that, but you kept on persisting, and then he led you on to something else. You have to also learn how to, listen to the examiner who is questioning you.
Okay, sir.
Okay. Don't try to lead an examiner when the examination findings are not with you.
Okay, sir.
Okay. Yeah. Good.
Thank you, sir.
Thank you, Dr. Ganpati. Thanks for joining. Thanks to Jailal sir for permitting you to give your presentation today. I think good luck to you, and already you are on study leave, sir was telling. So good luck for your upcoming exams.
Thank you, sir.
All the best to you. And I think we have Bhuvnesh already ready. Bhuvnesh, your issues are sorted out, ma? Sharing issues?
So shall I stop sharing, sir?
Yes, ma. Please stop
sir.
sharing. Ganapati. Good luck to you.
Thank you, sir.
Bhuvnesh, you have to unmute yourself.
Yes, sir. Good evening, sir.
Good evening. So you can start your PPT, introduce yourself, your unit chief, your head of the department, and start your presentation.
Yes, sir. Good evening, sirs. I'm Dr. C.V.R. Neshwar, a second-year general surgical resident from Stanley Medical College. I belong to Professor Dr. S.P. Gayatri ma'am's unit, and she's a professor and head of her department, sir. So I have a case presentation on carcinoma tongue today, sirs. A 55-year-old male patient, Mr. Subramani, hailing from Chennai, a petrol tanker cleaner, came with complaint of growth over the tongue for the past 3 months. History of presenting illness, he presented with a history of ulceroproliferative growth over the tongue for the past 3 months, which he attributes to trauma sustained 3 months back. It was insidious in onset, rapidly progressive in nature. Initially, it was small in size and began over the right lateral border, and it grew to the present size. There was no history of bleeding. It was associated with pain, which is of pricking type, gradual in onset, intermittent in nature, and the pain was referred to the right ear. And the pain was aggravated on chewing movements, on tongue movements, and was relieved on medication. There's a history of dysarthria, history of excessive salivation and drooling of saliva, history of difficulty in chewing, which is due to pain, mostly on the right side, history of difficulty in tongue movements, history of dental caries and poor oral hygiene, history of loss and loosening of teeth, which occurred one by one, history of difficulty in swallowing, and he had no history of halitosis, no history of sharp teeth, no history of loose fitting dentures, no history of other swellings elsewhere in the oral cavity or the neck, no history of chest pain, no history of cough or breathlessness, no history of loss of weight or appetite. Past history, he had no previous similar illnesses in the past, and he had no prior history of radiation exposure. He had a prior history of laparotomy done for perforation peritonitis 30 years back, but records were not available with the patient. He had no history of prior pre-malignant lesions over the tongue or the oral cavity. He had no comorbidities. He was a chronic betel nut chewer for several years. He consumed them almost up to 3 times per day, mixed with lime. And he placed the quid on the right side of the mouth, and usually he went to sleep after quid chewing. He is not a smoker and not a tobacco chewer, and he consumes alcohol occasionally. And he is able to tolerate semi-solids and liquids. He had no relevant family history. Examination: the patient was made comfortable and examined in a well-lit room after obtaining consent.
Sorry to interrupt you.
Yes, sir.
What is your conclusion by your history, and what is the positive point in your history?
Sir, from the history alone, I think we can make out that from the acute onset and the rapid progression of symptoms, sir, and along with the history of pain, drooling of saliva, difficulty in chewing and swallowing, we can make out it's probably a malignant etiology, sir.
I'm not asking conclusion. What are the positive points in your history? I'm not asking diagnosis or your conclusion.
Okay, sir. So sir, he had a history of a growth over the tongue, sir. He had a history of difficulty in and there was pain over the lesion. He had a history of difficulty in speech, saliva, and he had excessive salivation. Difficulty
Only pain
in
over the lesion, not referred pain.
So he also had referred pain to the right ear, sir.
Why there is referred pain?
Sir, as far as sir, the tongue is supplied by the lingual nerve, sir. The lingual nerve carries the general sensations to the anterior two-third of the tongue. The lingual nerve and the auriculotemporal nerve are supplied by the marginal mandibular nerve, sir. So, due to referral of pain to the auriculotemporal nerve, the pain is referred to the TMJ region and to the tympanic membrane
branch
region,
of the
sir.
mandibular division of the trigeminal nerve. That's why.
Yes, sir. Yes, sir. Yes, sir.
Why there is excessive salivation? I will
So
explain it.
excessive salivation can probably be attributed due to two factors. One, due to irritation of the nerve endings of the tongue by the lesion, and also it can be due to inability or difficulty in swallowing the saliva. So since this swallowing peristaltic movement starts at the tip of the tongue, um, it leads to pooling of saliva, sir.
Why there is a
Can I
pain at
ask
the
you?
sorry?
Yes, sir.
Yes,
Why there is
Nishikant, what?
pain at the local site?
Sir, sorry, sir.
Why there is a pain at the ulcer site or ulceroproliferative growth site?
Sir, usually, carcinoma tongue is not carcinoma tongue and carcinomas of the oral cavity do not usually present with pain as the first symptom. Pain
Very
can
good.
be attributed due to rapid increase in the tumor size, which can lead to necrosis in the central parts, which can lead to pain, or it can also be due to nerve involvement, sir.
Due to nerve involvement. Very
Nerve
good.
involvement, sir.
Here I wanted to know, you said
Yes, sir.
there's a growth in the lateral part of the tongue, no? Right?
Yes,
Main
sir.
chief complaint.
Yes, sir.
And you have mentioned that of loosening of the teeth, right? In
Yes, sir. Yes, sir.
positive
Yes, sir.
loss
Yes,
of.
sir.
How do you correlate this?
Sir, we can.
Clinical.
Sorry, sir.
There is a growth over the lateral part of the tongue. At the same
Yes, sir. Yes, sir.
time, this patienting, there's a loosening of the teeth, right? On the same side, obviously, I suppose. Can you
No, sir.
correlate
Actually,
these things?
Sir,
Or it is just because of like a senile, there is a loss of teeth.
It is due to poor oral hygiene. So he was not maintaining his oral hygiene properly, sir. His lower jaw was entirely edentulous, and the upper jaw there were only
Right.
4 teeth left, sir. It wasn't.
Okay.
Yes, sir.
But if this happens, this type of history happens without, I mean, there is a growth over the tongue. Do you interpret in a different way? There is something arising from the alveolus. Okay, go ahead.
Yes, sir. Yes, sir. So, examination. The patient was made comfortable and examined in a well-lit room after obtaining consent. The patient was conscious, oriented to time, place, and person. His hydration was adequate. He belonged to performance status 1. His vitals were stable, and there was no pallor, icterus, cyanosis clubbing, generalized lymphadenopathy, or pitting pedal edema. Oral examination revealed adequate mouth opening. There's no facial asymmetry. His dental hygiene was poor with multiple teeth loss. The lower jaw was edentulous, and there's no halitosis. On inspection, there was a proliferative growth of size 4x3 centimeter present over the right lateral border of the anterior two-thirds of the tongue, 2 centimeter from the circumvallate papilla posteriorly, and it extends to the tip of the tongue and crosses the midline, involving the left lateral border of the anterior 1/3 of the tongue. It also involves the floor of the mouth. It was irregular in shape. It had well-defined margins. There's no active bleeding or discharge from the lesions. There were no pre-malignant lesions. There was pooling of saliva, and the posterior 1/3 of the tongue was free on inspection. On palpation, the inspectory findings were confirmed. The lesion was tender. It was of friable consistency. It bled on touch. There was induration 1 centimeter around the lesion. The floor of the mouth was involved. There was no other lesion palpable over the lip, the buccal mucosa, the alveoli, the hard palate, or the retromolar trigone. There was no thickening of the mandible. Cervical lymph node examination revealed enlarged right level 1B node measuring 2x1 centimeter, which was firm in consistency, fixed, and it was non-tender. And bilateral level 2 nodes were also present, each measuring 1x1 centimeter, which were firm in consistency, mobile, and non-tender. So from the above clinical history and physical examination, we can probably come to a diagnosis of a carcinoma of the tongue with bilateral cervical nodal metastasis. And the clinical TNM staging is T4A due to involvement of the floor of the mouth, N2C due to bilateral cervical node metastasis, and M0.
Bhunesh,
Yes, sir.
In your clinic examination, you have mentioned
Sir,
that there is no pre-malignant. What
sir,
are
I'm sorry,
the
sir. I was not able to hear
pre-malignant
you.
lesions?
Sorry, sir. I was not able to hear you properly, sir.
In clinical examination, you have mentioned that there is no pre-malignant lesion. So what are the pre-malignant lesions?
Sir, there are pre-malignant lesions and also pre-malignant precancerous conditions, sir. So pre-malignant lesions can be leukoplakia, erythroplakia, and chronic hypertrophic candidiasis, sir. Whereas precancerous
Okay.
conditions can be Plummer-Vinson syndrome, syphilitic glossitis, and submucous fibrosis, sir.
And you remember this? This 4 questions are
Definition
only
of
the
leukoplakia.
Sorry, sir.
What is leukoplakia?
So, leukoplakia can be defined as a white patch present over the buccal mucosa or the tongue, which cannot be explained by any other etiology or histopathological examination, sir, which is not related to any other syndrome.
Okay. Which leukoplakia is more prone for undergoing malignancy?
So, as far as leukoplakia goes, it is of mainly two types, sir. It can be homogeneous or speckled. The speckled nodular variant is of higher risk for going to malignancy, sir.
What about erythroplakia?
Erythroplakia, sir, is at a much higher risk of proceeding to malignancy, sir.
Okay. Proceed.
Yes, sir. So, I'd like to diagnose the patient as a case of CA tongue with bilateral cervical nodal metastasis belonging to T4A, T4A N2C M0.
What
And
are the findings suggestive of metastasis malignancy in your case?
sir, sorry, sir, I was not able to hear you properly, sir.
What is justification for malignancy in this case?
So, the age of the
Question
patient,
is
sir.
very simple.
Yes, sir. So, the age of the patient, sir, the male sex, the acute onset of the lesion, sir, and the rapid progression of growth. And symptoms.
Inspection wise, palpation wise.
Inspection
Palpation wise.
So, inspection-wise, the presence of a proliferative growth, sir, that is extending from the right lateral border to the left lateral border of the tongue, sir, and the lesion it had a friable consistency and it was bleeding on touch.
Okay, very good.
And also there is induration present around the lesion, sir, and it was also involving the floor of the mouth, thereby restricting the mobility of the tongue, sir. So all of these can point toward a malignant etiology, sir.
What about trismus? You are not mentioned about
Sir,
trismus.
no, sir. So the mouth opening was adequate, sir, for this patient. There was no trismus, sir.
Okay, sorry. Continue.
Yes.
And why you mentioned that there is no facial abnormality? Go to the first slide. Facial asymmetry. No facial asymmetry.
Yes, sir. Yes, sir.
How much was the induration around the lesion, and what was
So
the significance of that?
So induration was 1 centimeter around the lesion, sir. So while if
What
we
is
are
the
going for
significance of this finding?
so in lesions of the tongue, when we are going for a surgical procedure such as a wide local excision or partial or hemiglossectomies, we have to take the induration into account. The margins should include it should be beyond the region of induration, sir. So we should also take the induration into account, sir.
Okay.
Yes, sir.
Right. Go ahead.
Yes, sir.
Which nerve is commonly involved in CA tongue?
So the lingual nerve can be involved, is most commonly involved in CA tongue, sir. Since it
Lingual
carries
or
a
hypoglossal?
So actually, I'd like to revise my answer, sir. The hypoglossal nerve is more commonly involved, sir. When it is
Okay.
involved during protrusion of the tongue deviates towards the side of the lesion, sir.
Same side.
Right.
Okay, very good.
Yes,
Same
sir.
side, right?
And if there is a numbness over the chin or lower jaw, which nerve will involve?
The lesion might also involve the inferior alveolar nerve, sir, that by leading to numbness over the jaw.
Okay, good. Proceed.
Yes, sir. So I'd like to after assessing the nutritional status and the HB status of the patient and taking the routine investigations, I'd like to confirm my diagnosis first, sir. So for that, I would like to do a edge wedge biopsy of the ulcer, sir. And apart from that, I would also like to carry out imaging investigations, sir, such as
What is
ultrasonogram of the
the
neck.
edge wedge biopsy?
So edge wedge biopsy, the abnormal tissue along with a bit of normal tissue is taken, sir, so that the pathology can be studied, sir. As in, since CA tongue is most commonly to a squamous cell etiology, we have to edge wedge biopsy incorporates the pathological lesion as well as the normal tissue, sir, so as to allow for comparison.
Because on central part there is a necrosis. That's why
Yes, sir.
always
Yes,
you
sir.
have to go for the
Yes, sir. Yes,
biopsy.
sir.
Biopsy
Yes,
from
sir.
the edge of the ulcer.
Yes, sir.
Okay.
You said in the history it bleeds on touch, right?
Yes, sir. Yes, sir. Yes, sir.
And if suppose it is known that many of the times while taking biopsy they bleed very heavily, what will you do?
Sir, we have to pack the mouth, sir. We have to pack the mouth, ask the patient to be in a sitting position. And if the bleeding is relentless, we can
Will you
apply
pack the mouth?
adrenaline pack also can be kept, sir.
Why do these malignancies bleed commonly? Bleed on touch. Normally, if you get a cut, it doesn't bleed, it stops automatically. Why do they bleed, malignancies?
So malignancies are always associated with the abnormal increase in growth factor, sir. So in this lesion, there might be the increased production of VEGF, which may lead to increased angiogenesis, sir. These vessels are due to increased neovascularization, and also these vessels are highly friable, sir. So due to that, even a
Right,
little handling can cause bleeding, sir.
right, correct. Friability, and
Yes, sir.
just
Yes, sir.
neovascularizations are not normal vessels. Right.
Yes, sir.
Go ahead.
Bhunesh, what is field cancerization? What do you understand by field cancerization? Bhunesh, can you listen me? Bhunesh, are you there? Bhunesh? We lost his connection probably, isn't it?
Bhunesh, are you okay? Bhunesh? Are you able to hear us, Bhunesh?
Hello?
Yeah, you have to set right your mic. We are unable to hear you at all.
Sir, just a minute, sir. Just a minute.
Yeah.
Hello.
Start your PowerPoint, ma.
Yes, sir. Just. Sir, am I audible, sir?
Yeah, you are good to go. Switch on your video.
Yes, sir. Yes, sir. Sorry about the delay, sir.
Go ahead.
There's some connectivity issue. That's right. Sorry.
Okay, Bhunesh, I was asking you, what is field
sir.
cancerization?
So field cancerization is the development of multiple synchronous lesions, sir, in and around the oral cavity, and also it includes the upper aerodigestive tract, sir. So to test for field cancerization, a thorough oral examination is needed, as well as examination either indirect laryngoscopy or direct laryngoscopy is needed, sir. So as to see whether other lesions are present, sir, in the upper aerodigestive tract.
What is chromoendoscopy? Are you there?
So yes, sir, I'm here, sir.
You know what is chromoendoscopy?
So I know it's a recent advance.
Say, endoscopy based on the giving certain dyes.
Okay, sir.
Okay.
Okay,
so
sir.
To do the chromoendoscopy.
Yes, sir.
Like in the CS cervix, you know what is that?
Yes, sir. Via Valley, sir. After application of acetic acid.
Yes. You know? So similarly, also you can do in the oral cavity also.
Okay, sir.
You can use the iodine. You can use the vital blue dyes.
Okay, sir.
And you can find that which is the area which is suspicious area is there.
Okay, sir.
And you can go for the biopsy from that.
Okay, sir.
Especially if the patient is having the field cancerization. This is
Yes,
the
sir.
one way by which you can detect does the patient has got any other malignancy or not.
Yes, sir. Yes.
Can you tell what are the various viruses which are associated with the oral cancer?
So the most common virus would have to be human papilloma virus, sir. After the Epstein-Barr virus can also be involved with this condition, sir.
Okay. Is a HIV patient more prone to have the oral cancer or not?
Sir, due to generally immunocompromised status, HIV patients are at a higher risk, sir.
And that is mainly because of the human papilloma virus.
Yes, sir. Yes, sir. Yes, sir.
So what is the difference between a patient who has got a HPV positive and who is HP negative? What are the various differences between these two?
Sir,
Do you know that?
Yes, sir.
Or should I answer that?
So HPV positive lesions tend to have a better prognosis and they're more responsive to treatment, sir. Whereas HPV negative, they are more commonly associated with the older age group and they're refractory to treatment, sir.
Yes. And where do you get more of the notes? In the HPV
Sir,
positive or HPV negative?
HPV.
Yeah, usually the
HPV negative, sir.
No, in HPV you get the large metastatic nodes.
Okay.
So young patients who has got the higher stage as compared to the non-HPV, they've got the large metastatic nodes.
Yes, sir.
Are they more common in oral cancer or in the oropharyngeal?
Sir, more common in the oropharyngeal region, sir.
More common in the oropharyngeal and not in the oral cancer. And
Yes, sir.
prognosis-wise, are they better than that HPV negative or?
Sir, HPV positive has a better prognosis than the HPV negative variety, sir.
Yes. Though being the big tumors, but still they have got the better prognosis as compared to the HPV negative.
Yes.
Okay. So now in your patient, you said
sir.
the floor of the mouth is involved, isn't it?
Yes, sir. Yes, sir.
So did you check for the mandible, whether that is involved or not?
Sir, yes, sir, I did, sir. There's no the thickening present over the mandible, sir. And on digital examination also, I was not able to feel any mandibular involvement, sir. There's no thickening, sir, or tenderness over the mandible, sir.
And what about the teeth, whether they were absent or?
So the lower jaw is completely edentulous, sir. There are just 4 teeth present in the upper jaw, sir. The 2 incisors, the right canine, and the right premolar, sir.
And why the tooth were lost?
So the patient, he said it was due to poor oral hygiene, sir. So probably, and he had a history of multiple caries. So it is probably due to that, sir, and not mandibular involvement by deletion. Mandibular or maxillary involvement by deletion, sir.
Does your patient has got the submucous fibrosis?
Sir, no, sir. My patient did not have submucous fibrosis, sir.
How do
Though
you
he
say
had
that?
a history. So, submucous fibrosis, it leads to decreased mouth opening, sir, and causes trismus, sir. For this
Good.
patient, the mouth opening was adequate, sir. And
Okay.
also on palpation, there were no strands felt in the floor of the mouth or the buccal mucosa, sir.
Good.
Or yes, sir.
Okay. You want to keep any differential diagnosis here, or just say it's a carcinoma tongue of the lateral margin, is it?
So my main diagnosis would be carcinoma tongue only, sir.
Okay. Anything
Yes,
else? Remote possibility? You know, it's a big proliferative growth which is there.
Yes, sir. Might be can also be condyloma acuminata due to HPV, sir. Or it
Yes.
can be syphilitic condyloma also, sir. But these are very
Yeah,
rare
very rare. Yeah, that's right. Yeah, they are very, very rare, but that possibility you can keep as a very remote possibility. You know?
Yes.
Right. So how you are planning for this patient? How you are going ahead with this?
So first I'd like to investigate the patient, sir. After the basic investigations, I'd like to confirm my diagnosis with the edge wedge biopsy. Then I would also like to carry out some imaging studies for this patient, sir. There's ultrasonogram of the neck.
So
And
you will do a biopsy first, or will you do the imaging first?
Sir, it would be wiser to do the imaging first, sir, before distorting the anatomy.
So which imaging you want to do? Now in this patient, such a big lesion is there. So
Yes,
probably not much bothered about that, but definitely in a smaller lesion, which is there, you will go for the imaging first and followed by the biopsy.
Yes, sir. Yes.
Right. So what type of the imaging you want to do in this patient?
So, so I'd like to take a CT scan of the neck, sir, and the MRI of the oral cavity, sir. The CT scan of the neck will let me know about the bone, whether there is any bone erosions, and also about the node status, sir, and about the extent of the lesion also. And from the MRI of the oral cavity, I'll be able to know better about the soft tissue status and the involvement of the intrinsic or the extrinsic muscles of the tongue.
So the patient gives you a choice that I don't have the money. Will you do the MRI or will you do the CT scan in this patient?
So it would be better to go with the CT, sir, since it's more informative.
No, but you know, in the tongue, you have to decide that what type of the glossectomy you are going to do.
Yes, sir.
Okay. So probably you are more interested to see that how much is the invasion of the tongue, which is there.
Yes, sir. Because in this patient, I would like to know about the operability before proceeding, sir. So for that, I would like to go for a CT, sir. If it was a small lesion, then we can go for an MRI, sir. So to know about the resectability, sir.
Okay. So anything has been done in this patient?
Sir, no, sir. This patient was just admitted 2 days back, sir.
Okay. Now you are doing a biopsy for this patient.
Yes, sir.
What report do you expect?
Sir, pathology wise, there are three types of carcinomas possible in the tongue, sir. Out of which the most common is squamous cell carcinoma, followed by adenosquamous carcinoma or malignant melanomas also, sir. But I'll expect a report of squamous cell carcinoma, sir.
So how do you say on pathology it is a squamous cell carcinoma?
So there'll be hyperkeratinization, sir, and also there'll be keratin pulse formation, sir. Okay. So from that, I'd be able to say it's a squamous cell carcinoma.
How do we say whether it is a well differentiated or whether it is a poorly or it's a moderately one? What are the criteria for that?
So the degree of anaplasia should be seen, sir, in such slides. As in how
more creatine pulse, what does that mean?
So more keratin pulse means that it resembles the mother tissue more, sir. As in the skin produces keratin. So by resembling the mother tissue more, it produces more keratin. So it means it's well differentiated.
Well, good. Right. Now, what are the various ways to carry out the biopsy from the tongue lesion?
Sir, we can go for an edge wedge biopsy, an incisional biopsy, or if it's a very small lesion, we can go for a wide local excision, sir.
Can you just what is the difference between incision biopsy and excision biopsy? When you do the incision biopsy and when you do the excision biopsy?
So in case of very small lesions, we can carry out an excision biopsy, sir. Excision
What
biopsy,
is that small lesion? 5 millimeters, 8 millimeters, 1 centimeter, 2 centimeter, 3 centimeter. What is that small lesion?
So less than 1 centimeter, sir.
No, as a general, if you look at, if somebody asks you, not related to the CA tongue only, but as such general, for any tumor which is there, if the tumor is less than 2 to 3 centimeters,
2 to 3 centimeters,
you can go for the excision biopsy.
Yes, sir.
But if it is more than that, then you have to go for the
incision biopsy.
I'm not saying about the tongue here, okay, but in general, I'm telling that. No?
Yes, sir.
What are the other ways by which you can do the biopsy?
So we can also get edge wedge biopsy can also be done, sir.
Yes.
And wide local excision can also be carried out, sir. Punch biopsies are not preferred in CA tongue, sir.
Okay. So what are the pre-malignant conditions for the CA tongue?
Yes, sir. There are pre-malignant conditions and pre-malignant lesions, sir. Conditions, submucous fibrosis.
I'm not talking about the oral cancer, isn't it?
Yes, sir.
I'm not talking about the oral cancer. I'm talking about the tongue cancer.
Sir,
leukoplakia,
erythroplakia, sir.
Yes.
And chronic hypertrophic candidiasis, sir.
Yes.
Submucous fibrosis.
Syphilis?
Syphilitic glossitis.
Yes.
Yes, sir.
What are the various ways the syphilis can affect the oral cavity? Primary syphilis, secondary syphilis, and tertiary syphilis.
Yes, sir. So primary syphilis, it can cause Hunterian chancre inside the oral cavity, sir. It presents as a small papule, which is painless and breaks down into a shallow-based ulcer, sir. Which is it is not tender and has a rubbery consistency, sir. And also nodes may be enlarged at this point, which are again firm and rubbery and non-tender, sir. So this occurs during the first phase. During the secondary syphilis, snail track ulcerations and mucosal patches can form, sir.
Good.
And during tertiary syphilis, gammata can form, sir. Gammata usually affects the hard palate or the dorsum of the tongue, sir.
Good.
And also during syphilis, transverse creases can also form on the tongue, sir. No, not transverse, longitudinal creases, sir.
Very good. Yeah. Okay, so you have done the biopsy in this patient. It says it is a well-differentiated carcinoma.
Yes, sir.
MRI shows that there is crossover of the midline.
Yes, sir.
Okay. So, any further, you want to do the CT scan, isn't it? CT scan
yes,
for?
Sir. Sir, for knowing the bony invasion or invasion of the nearby structures, sir, and also for knowing the nodal status, sir.
Any other modality by which you can know the bony invasion?
So orthopantomogram used to be the first go-to investigation, sir.
Right. Good. Very good. Yeah. Okay.
Have you done X-ray chest in this patient?
Sir, yes, sir. We also carried out an X-ray chest, sir. Carcinoma tongues have been known to
extensive management of something very major or surgical something.
Yes,
is it important to do X-ray chest?
Sir, carcinoma tongue. So X-ray chest serves two purposes. One for the anesthetic fitness point of view, and another carcinoma tongues have also been known to metastasize late, sir. It can metastasize to lungs or the bone. So in those cases, we need a metastatic workup, sir.
Yeah, definitely.
Yes.
Okay.
Good.
So you want to confirm whether the lymph nodes you are palpating,
yes,
are
sir.
they just inflammatory lymph nodes or they are malignant?
Yes, sir.
What you are going to do?
Sir, first on palpation itself, whether there's tenderness or not can be elicited, sir. And on we can also take an FNAC of the node, sir. If it shows a reactive picture, then it's probably due to inflammation, sir. Since
So
it's since the
patient,
oral
if the
cavity is,
lymph nodes are there,
yes, sir.
will you think that they are inflammatory only and you will just treat it by the antibiotics, or will you like to be more aggressive in this patient?
Sir, it would be wiser to assume that it's malignant and
Sure.
proceed, sir.
Yes, definitely. Okay. So you have done biopsy has come out to be squamous cell carcinoma.
Yes, sir.
Nodes are positive.
Yes, sir.
What is your further plan now?
So for my patient, I would like to, due to the extensive involvement, sir, that is a T4A lesion since the floor of the mouth, and also the intrinsic muscles also seem to be involved from the symptoms, sir. So for this patient, and along with bilateral cervical node metastases, it is better to go for a concurrent chemo radiation and then reassess the patient, sir. Concurrent chemo radiation with a curative intent, then reassess the patient, and then we can we can decide whether surgery is needed, sir.
What are the various ways you can give the radiation to the tongue?
So we can either give a external beam radiotherapy or a brachytherapy, sir.
What is the difference between these two?
The external beam therapy is usually a cobalt-60 machine or LINAC. So the source is external to the body, sir. Whereas in case of brachytherapy, the radioactive material is instilled inside a natural cavity, sir.
Is it always instilled or something else can be done for
And
the
also it can be
brachytherapy?
kept close to the lesion, sir.
Like a patient has a cancer of the penis is there?
Yes, sir. A mold can be placed on the penis, sir.
Mold can be put there. Good. And what is the difference in the duration of these treatments between the brachy and the teletherapy?
Sir, brachytherapy needs a prolonged sitting, sir. Whereas teletherapy has a relatively shorter phase, sir. But systemic side effects are more in EBRT, sir.
No, but are you sure that teletherapy is shorter than the brachytherapy? If you look at the total duration of the exposure which is given, is it shorter in the brachy or in the tele?
So no, each session is shorter, sir, but more cycles are needed, sir, in external beam.
In external beam, isn't it?
Yes, sir.
So the duration is more in the external beam, is it?
Yes, sir. On
brachy
total
is
duration
shorter,
is
yeah.
more.
It's a shorter duration is there.
Yes.
Okay. So you did that, and now that your tongue lesion which is there has become much smaller then.
Yes, sir.
Then anything, how to go further?
Sir, then we can reassess the need for surgery, sir.
Yes.
If the lesion is lesser than 1 centimeter in size, along with the surrounding indication, that is, we can go for a wide local excision, sir, or with 1 to 2 centimeters in size, a partial glossectomy or a hemiglossectomy, sir.
Okay. And what are the limits?
Wide local excision with how much margin?
Sir, 2 centimeter margin, sir.
Wide local excision.
Sorry, 1 centimeter margin, sir. 1 centimeter, sir.
Okay.
What are the lymph nodes?
For the lymph nodes, sir, in case of a node negative neck, sir,
No,
those patients,
in your patient, okay.
Sir, in this patient, we have to go for a bilateral modified radical neck dissection, sir.
Okay. So what do you understand by modified radical neck dissection?
Sir, in modified radical neck dissection, the IJV, the sternocleidomastoid and spinal axillary nerve are sacrificed, sir.
Okay, so
And also the...
If you save one structure out of these three, which one you like to save?
Sir, the IJV, sir?
No. IJV you can sacrifice, isn't it? At least on one side you can sacrifice. At least on one side you can very well sacrifice.
So then the spinal accessory, sir.
Yeah, spinal accessory nerve. No? So you like to save the spinal accessory nerve. If you have to given a choice that which one you want to save out of these three, one structure.
Yes.
Okay. Now, you're done in this. What is a commando operation, by the way? What do you
The
understand by
commando
commando?
operation is a composite resection along with a mandibulectomy and en bloc node removal, sir.
Now, what does the commando stands for?
Sir, composite resection with mandibulectomy and node dissection, sir.
Combined mandibulectomy with node dissection operation. No? That is the
Yes,
commando
sir.
operation.
Yes, sir.
Okay. Now, what are the components of the commando operation?
So the lesion would be a composite resection of the lesion will be done, sir, and a part of the mandible will also be removed, sir. It was based on the idea that the lymphatic supply, while the lymphatics were draining, since it passes closer to the mandible was involved, sir. So they're also taking a part of the mandible, and also the lymph nodes were removed and blocked, sir.
Okay. What are the various types of resection of the excision of the mandible?
Sir, currently marginal mandibulectomy is being performed, sir, in which the lesion, along with leaving a 1 centimeter margin of the mandible is removed, sir. So it is based on the idea that the invasion of the tumor to the mandible occurs via pores in the edentulous jaw, or in case of dentate persons, via the alveolar process, sir. So part of the mandible is being removed, sir.
So in your patient who is edentulous,
yes,
will
sir,
it be wiser to go for a marginal mandibulectomy?
Sir, since there is a lesser chance of the mandible getting involved in this patient,
No, if you have to remove the mandible in a
yes, sir.
edentulous patient, is it wiser to go for a marginal mandibulectomy? Okay, the height of the mandible is very small there.
Yes, sir. Yes, sir.
Okay, so you won't be able to do the marginal mandibulectomy.
Okay,
and you
sir.
will be exposing the inferior alveolar nerve which is there, which is running through that.
Yes, sir. Yes,
Okay.
sir.
So in those cases, you have to go for the segmental mandibulectomy
Okay.
rather than the marginal mandibulectomy.
Okay.
Okay. Now,
Dunesh,
yeah.
Yes, sir.
what are different incision used for radical neck dissections? Name of incisions.
Sir, hockey stick incision, sir.
Because in our time, this is commonly a short note. And it
yes,
is
sir. Yes, sir.
the favorite question of examiner. Advantage, disadvantage, and different types of incisions.
Yes, sir.
Christ incision, Wart incision, margin incision, hockey stick, McPhee incision.
Hockey stick, yes, sir. Yes, sir.
Just check it.
Yes, sir.
One last question. How the
Yes,
patient of the CA tongue will die?
Sir, CA tongue, the patient can die due to inhalation bronchopneumonia, sir. They can also go for cachexia, and the lesion might cause compression of the carotid and cause carotid blowout, sir, or the lymph nodes, enlarged lymph nodes can compress on the vital structures in the neck, sir.
Okay, very good.
Yes.
So when you're doing the neck dissection for these patients,
yes, sir,
what are the various ways to prevent the carotid blowout? Various techniques which are there, or various maneuvers which are there to prevent the carotid blowout. Are you there?
Yes, sir. Yes, I'm here, sir.
Okay. Okay. Any idea? No.
Sir, no, sir. I'm sorry, sir.
It is most of the time it is because of the infection.
Yes.
And if it is a bare carotid is there, so that is why you preserve the carotid sheath.
Okay, sir.
You do not make it bare.
Okay, sir.
So you will prevent the carotid sheath. You will try to make your incision in the way, like in the case of Hayes-Martin incision, which is there, where there are 4 flaps, and all those 4 flaps, they come at an angle right at the carotid.
Okay, sir.
So you have to make your flaps different way that those angle does not come at the carotids there.
Carotid.
Okay. So that there is no angular necrosis is there.
Okay, sir.
Angles the necrose. So there is no angular necrosis is there.
Okay, sir.
Okay. And the third way is that you can cover it with some muscle.
Okay, sir.
You know which muscle can cover that carotids?
So sternocleidomastoid, sir.
Yeah. Sternocleidomastoid, okay, in case if you are preserving that. No. But if you are not preserving the classical radical neck dissection, you are also removing the sternocleidomastoid.
Sternocleidomastoid, yes, sir.
So which other muscle can be used? Now, like in case of inguinal block dissection, if you have to prevent the femoral blowout, can you use
Yes,
any
sir.
muscle to cover that?
Sir, iliacus can be.
No, not iliacus. Sartorius.
Okay, sir.
Okay, sartorius is used for that purpose.
Okay, sir.
Okay. And in the neck, again, a long strip of muscle is there, which can be used for that. That's the levator scapulae.
Okay, sir.
Okay, levator scapulae, when you're dissecting on the posterior side, you can find the levator scapulae and
Okay,
you can
sir.
turn it over the carotids. So
Okay, sir.
that's the way you can cover the carotids to prevent the carotid blowout.
Okay, sir.
What is the difference between a neck dissection on the right side and on the left side?
So the crossing of the IJV on the left side is the IJV's course is more tortuous and longer on the left side, sir. Whereas on the right side it is straightforward and it enters the IVC, sir.
It's all the similar course on the, but you may be right, but that is not the main reason. No? Main difference is
Sir,
you have done your very good neck dissection, the drain was there and you are draining the white thing from that.
So emptying of the thoracic duct, sir.
Yes.
It occurs on the it is NTV on the left subclavian, sir.
Yeah, on the left side,
Yes, sir.
So if that is the main difference between the dissection on the right and the left side, that you have to be very careful about that.
Yes, sir.
Okay, otherwise if you injure that, this patient will have the chyluria, or not the chyluria, but the chylous drain will be there.
Yes.
Okay. What are the other complications of the neck dissection? When you do the neck dissection, what are the other complications? If you have damaged the spinal accessory nerve, what will happen?
Sir, weakness of the sternocleidomastoid and the trapezius can occur, so it can lead to.
So what it will lead?
Sir, lead to weakness of the shoulder, sir. Inability to shrug the shoulder.
And it will lead to further with the frozen shoulder.
Yes.
Okay, so the weakness will be there along with the frozen shoulder will be there.
Yes, sir.
Right. So in this patient,
yes, sir,
you have done no, you have not done anything, isn't it? Are you going to plan the treatment for this patient alone, or?
So no, sir, it is a multidisciplinary approach, sir. Yes. So for this patient, it would be best to go with
always in the examination when such type of the patients are there, that yes, should be a word which has to be always used. Okay. So yes, whenever you are asked about the treatment of such patients, yes, you will say that this patient will be discussed in the MDT, and yes, then sir, we are going to decide about that. Okay. Yes, so that word must come whenever yes, you are discussing about such a
yes, sir,
case.
Yes.
Okay. Any other questions? Or
you said at the beginning there can be some role of chemotherapy because of very extensive lesion T4 with lymph nodes. Yes, what sir, is the common drugs with complications?
Sir, cisplatin can be given, sir, for this patient. But cisplatin, the most common complication is post-chemo nausea and vomiting, sir.
That is common for almost all chemotherapeutic agents.
Yes, sir. And cisplatin Cisplatin related renal toxicity can also occur, sir.
Okay.
Yes, sir.
What is the toxicity of the bleomycin, which is also sometimes
Yes,
in the oral
that is
cancer?
the drug which is given.
Sir,
Bleomycin, right.
bleomycin can lead to pulmonary fibrosis, sir.
What is the limiting dose for that, for the bleomycin?
Limiting dose, I think 0.1 mg per kg. I'm not sure, sir. I'm not sure about the exact dose, sir.
In the adults, it's around 450 milligrams. That is the total dose which you can deliver to a patient in the lifetime. Yeah.
Yes, sir.
Okay. What is the toxicity of the adriamycin?
Adriamycin can lead to cardiotoxicity, sir.
Good. Vincristine?
Vincristine can lead to aplastic anemia, sir. And bone marrow suppression, sir. More, it will be a better term, sir. Bone marrow suppression.
Neuritis, you know?
Yes, sir. Neuritis, sir.
Vinca alkaloids can cause the neuritis. No?
Neuritis. Yes, sir.
Okay, good. You're very well prepared, yeah.
Thank you, sir.
Dr. Kanag.
அப்புறாம 2 மணி நேரம் உட்கார்ந்து இருந்திருக்காரு. ஃபுல்லா 2 பிரசன்டேஷனுக்கு இவர் மட்டும் தான் ஃபுல்லா இருந்தாரு.
Dr. Kanag was there?
Yeah, done well.
Thank you, sir. Thank you.
Theoretically very sound that way.
Thank you so much, sir.
Nice presentation, Bhunesh.
Thank you, sir. Thank you, sir. Thank you, sir.
Dr. Kanagal, can we close now? Bhunesh, you want to ask any question from us?
Nothing specific, sir.
Okay.
No, sir.
Dr. Guzer, can we close now?
I think Dr. Kanagway is not here.
Yeah, Dr. Kanagway is probably not there.
So otherwise we can close, I think.
Dr. Srinivasan is also probably not there. Yeah. Yeah, Dr. Kanagway is coming here. Dr. Kanagway?
Yes, sir.
Yeah. Can we close now or?
Hello.
Hello.
Yes, sir. I'm here with you, sir.
Yeah.
We close, sir.
Yeah. He's an excellent boy. You know, very well read.
Credits to the teacher, sir.
Thank you.
In fact, he was given very short time to prepare for the case. Gayatri madam, I think yesterday only he sent the PPT at all.
Okay.
Yes,
so,
sir.
I think the regards to your professor and head of the department, Gayatri ma'am. Thank you very much. Do you have any doubts to get clarified, Bhunesh?
Sir, no doubts as of now, sir.
Okay. Good luck to you. Are you giving exams in the coming year or the next year?
Sir, no, sir. I just started my second year of residency, sir.
Fantastic.
Oh, that's very good. That's very good. Excellent.
Thank you. Thank you.
Good luck. Good luck. Faculty, thank you for taking all the pains to come again. I'm happy to share we have crossed 451,500 views as of today. And I think I wish the journey continues. And when I asked Jagdish sir, they immediately agreed. And in fact, Nishikant sir also agreed. Saha sir agreed. So that is the spirit which keeps us going, and we look forward for more longer associations. Dalvi sir, are you with us? I think he left. So he will have a bunch of questions to ask. Anyway, good luck to students who are giving exams, and thanks for joining us this afternoon. So we look forward to have you. Sir, any other faculty would like to give any comments, or can we call a close, sir?
Yes, I think we had a good discussion and he had done very well. Excellent, rather.
Thank you very much, sir. Thank you very much.